important lesion. Not only it is more common, it's also has got many findings which examiners are interested in asking you in examination. So the aortic regurgitation, it can be an acute aortic regurgitation and it can be a chronic aortic regurgitation, like mitral regurgitation, which can be acute and chronic as well. So acute aortic regurgitation, infective endocarditis, prosthetic valve dysfunction, aortic dissection, trauma, systemic hypertension. While chronic aortic regurgitation is seen in many conditions, of these more common is rheumatic heart disease, congenital bicuspid aortic valve, infective endocarditis, poorly controlled chronic hypertension, Marfan syndrome, systemic medial necrosis, osteogenesis imperfecta, Ehlers-Danlos syndrome, tertiary syphilis. So many of these are connective tissue disorders related to aorta, and then you've got diseases like spondylitis, ankylosing spondylitis, rheumatoid arthritis, SLE, Behçet's disease, giant cell arteritis, Takayasu's disease, fenfluramine and dexfenfluramine. So all these can result in chronic aortic regurgitation, while the acute aortic regurgitation is in infective endocarditis and practically prosthetic valve dysfunction. Now what happens in aortic stenosis, aortic regurgitation? Elevated LV and diastolic volume and pressure. What happens in aortic regurgitation? The blood comes back into the left ventricle. So the end diastolic volume increases. So as the end diastolic volume increases, the end diastolic pressure will also increase. There is increased LV preload, LV dilatation and LV hypertrophy. There is increased stroke volume and there is increased ejection fraction, means the cardiac output starts increasing in these patients. There is further rising LV and diastolic volume leading to LV failure and myocardial ischemia. You see, LV and diastolic pressure increases rapidly, causing a rise in pulmonary venous pressure, resulting in dyspnea and pulmonary edema and acute aortic regurgitation. So acute aortic regurgitation presents similarly as acute mitral regurgitation. There is sudden onset of pulmonary edema. The patient becomes dyspneic suddenly, and if you are not really prepared or you do not know the background of the condition, it is difficult to diagnose and you may require an urgent echo to see what is going on. But if you are aware of the situation, you can figure out what has happened. Chronic AR presents with palpitations, head pounding, excessive diaphoresis. There is exertional dyspnea, orthopnea, PND, and congestive cardiac failure. Patient may have angina if end diastolic pressure compromises coronary filling perfusion pressures. So normally, what happens in aortic regurgitation? In systole, the blood goes forward, and diastole, it comes backward. It should fill the coronaries well, because the coronaries are filled in diastole. But if the end diastolic pressure in the left ventricle is high, it compromises coronary filling. If there is a lot of pressure in the left ventricle, it compresses the coronary arteries, and the blood is not normally filled into the coronary arteries. That can result in angina. Again, it remains asymptomatic for a long duration. Patient may not have symptoms for 10 to 15 years. But this is different from MS. In MS, you see the symptoms develop even later, and in aortic stenosis, even later than this. So this lesion presents, the regurgitant lesions, they generally present earlier than stenotic lesions. MR also presents slightly early in the course of disease as compared to MS. So the stenotic lesions, they present a little late, while the regurgitant lesions, they generally present a little earlier. The examination is very important. The most important is Corrigan pulse, which is also called water hammer pulse and collapsing pulse. So what you do is you hold the wrist of the patient in your palm, not like this. This is difficult to perceive. You hold it like this. You inform the patient that you are going to lift the arm and ask the patient if there is any problem in the shoulder or not. If the shoulder is painful, you not do it. You do it in a different arm. So what you do is you note the pulsation in the palm of your hand and then lift the hand upward and see what will happen. the force of pulse striking your palm will increase. So this is how do you do a collapsing pulse. You must know it, because this is, you have to examine when you're doing a general physical examination, cardiovascular examination, or any other examination of the patient. You have to record the character of the pulse. So this is one important character, the Corrigan or the water hammer pulse, which is seen classically in aortic regurgitation. It may be seen in other conditions as well, for example, in patent ductus arteriosus, or sometimes in pregnancy and the patients having severe anemia, beriberi, thyrotoxicosis. They can all have this sort of pulse. Then you got a lot of peripheral signs in the feature of collapsing pulse is a rapid rise and rapid fall. Patient may have these peripheral signs which are seen in aortic regurgitation. Some of these signs are seen in other conditions, but few of these signs are very hard signs for aortic regurgitation. If they are present, this is aortic regurgitation. The classical example is the Drosius sign, written at the bottom. What is the Drosius sign? Drosius sign is a to and fro murmur. It's a systolic diastolic murmur which is heard at the femoral. You place your stethoscope on the femoral artery. You may hear a systolic murmur, and then you change the position of your stethoscope, and you find at some position you hear a diastolic murmur as well. If you hear this diastolic component as well, this is Drosius murmur, and this is a very hard sign of aortic regurgitation. If Drosius sign is present, this is nothing but aortic regurgitation, but unfortunately this sign is seen in approximately 10 to 15% of the patient. This is not seen in a very large number of patients, but if it is present, this is aortic regurgitation. You may have this Traube sign, that is pistol shots heard over the femoral arteries. You may have this Muller signs, that is bobbing uvula. When you open the mouth, the patient's uvula is moving with pulsation. You may have this Quinicki sign, that is capillary pulsation. When you press this, you see the capillary border moving with the pulses. So this is present, the De Musset sign. You may have Hill sign, and you may have Becker sign. So you may have all these signs in the aortic regurgitation, but the most important is the Drosius sign. So you learn to pick the Drosius sign. Precordium, the apex shows there is ill-sustained heaving. Apex may be displaced downward and outward. So again, this is similar to the apex of MR, but this is more dynamic than the apex of the MR. The first heart sound is soft, second may be absent, A2 normal or accentuated if disease is due to aortic root problems. So the aortic regurgitation can be because of the problem in the aortic valve itself, or the aortic root can dilate and result in aortic regurgitation. If there is dilatation of the aortic ring, then there is going to be aortic regurgitation, as for example in Marfan syndrome. The ring becomes wide and now the valves cannot go up, they remain separate, so you have aortic regurgitation. The other problem is the valves, they are abnormal, so they cannot stand the pressure and then they collapse. So you have regurgitation because of the pressure. So it's the aortic ring, if it is problem, aortic root is a problem, you may have accentuated A2. Now you've got early diastolic murmur and precordium. This is a high pitch blowing decrescendo murmur, similar to the murmur of pulmonary regurgitation, heard in a different area. That is heard in the left side of the chest in the pulmonary area. This is heard in the aortic areas, A1 or A2. So this is a high pitch blowing decrescendo murmur. It's only in the early part of the diastole that we hear this murmur. It is best heard in the left third intercostal space with the patient sitting up, leaning forward, and breath held in forced expiration. You may hear this murmur. So if the patient is breathing, you may not hear this murmur. This is so high pitched that in the breath sounds you cannot hear it, and don't hear it in inspiration. What happens in expiration is that the aortic apparatus or the aorta moves forward towards the chest wall. So it becomes easier to hear this murmur. Aortic root disorder murmur is heard along the right sternal border. It's heard here. Cooing or musical murmur because of eversion or perforation of the aortic cusps. Longer the duration of murmur, severer the aortic regurgitation. It becomes short in cardiac failure. Because in cardiac failure, why it becomes short? Because the cardiac output is decreased. So the cardiac output is low, regurgitated volume will also be low. When less blood goes out of the heart, less blood will come back into the heart. So if the patient has developed heart failure, the murmur will diminish in intensity. Then you got certain flow murmurs which may be audible in aortic regurgitation. One is ejection systolic flow murmur, which may be heard as the murmur of aortic stenosis. So the patients may have only aortic regurgitation, but you may have a systolic murmur, ejection systolic murmur. Patient may have aortic regurgitation and aortic stenosis together. And again, patient has a murmur of aortic regurgitation and there is an ejection systolic murmur as well. Now, how would you differentiate this patient has aortic stenosis or no aortic stenosis with aortic regurgitation? Again, it's the pulse which is important. What sort of pulse you can see in combined aortic regurgitation and aortic stenosis? It's the dichrotic pulse with double peaks. So you have a pulse with double peaks. Again, assessed best at the carotid. So you may have a dichrotic pulse. And then you got Austin Flint murmur. It's soft, low pitch, rumbling, mid diastolic murmur, which is similar to the murmur of mitral regurgitation. This is because the regurgitant jet displaces the anterior mitral leaflet. The regurgitant jet strikes the anterior mitral leaflet and causes functional aortic stenosis. So again, this is a functional murmur which may be seen in aortic regurgitation. And this Austin Flint murmur, the patients, we need to differentiate, does the patient have aortic mitral stenosis or no mitral stenosis? The apex will help to find out that there is aortic mitral stenosis because the apex is tapping type of apex in this. And the second important thing is if the patient has accompanying mitral stenosis, it would change the pulse of the patient. Patient may not have that collapsing classical pulse of aortic regurgitation because of the MS. If there is significant MS, the volume in the left ventricle will decrease. What happens in MS? And diastolic volume in the left ventricle decreases because a lot of blood cannot flow from the left atrium into the left ventricle. So when there is left and diastolic volume is low, the classical AR pulse may not be there. So it is the peripheral signs, as I mentioned, are the most important, which tell you what is going on inside the heart. So you must be able to pick up the pulse, the JVP and the apex beat. That may tell you what is going on inside the heart. Auscultatory events are intensified by hand grip. When you increase the hand grip, it causes increase in peripheral vascular resistance. When there is peripheral vascular resistance which is increased, it will impede the forward movement of the blood and you will have a backward movement of the blood more than if it is not the increase of the afterload. Acute AR patient will have tachycardia, there may be pulsus alternans. Patient may have peripheral vasoconstriction, there is cyanosis, pulmonary edema. Normal LV pulse, the apex beat may be normal in these patients in acute AR. EDM and Austin Flint may be present but difficult to appreciate. Patient has acute pulmonary edema, there is tachycardia, so these murmurs are difficult to find out on examination. We go for certain routine testing like CBC, we go for VDRL for syphilis, electrolytes, LDH, and if required, we go for testing like patients testing for SLE or RA or ankylosing spondylitis. But then generally those conditions are self-explanatory and present clinically, so it's not difficult to pick those conditions. We can go for chest X-ray. You see there is big heart, the aorta is dilated, there is pulmonary congestion. ECG may show LV hypertrophy. Echo may show dilated LV with hyperdynamic left ventricular fluttering, anterior mitral leaflet, and Doppler defects showing the reflux. Similar changes can be seen in angiography, so we can go for cardiac CT and MRI as well. So these investigations, particularly the MRI, it's a newer investigation and it gives a very good picture of the aortic valve apparatus. How do we decide the murmur, the lesion is severe? Peripheral sign, increased peripheral signs, it means there is a high intensity lesion, and precordium presence of S3, LVH, Austin Flint murmur, and the duration of regurgitant murmur. The duration of EDM, it means it's more severe lesion. So these are the clinical features which tell us about the severity of the lesion. Differential diagnosis I've already discussed. Management. Medical management is generally not the treatment of choice. Medical management is reserved for some patients. Medical management is vasodilators, because you increase the peripheral resistance, the forward runoff improves. So when the arterioles are constricted, the more blood is going to come back. But if the arterioles are open, the more blood is going to go forward, the regurgitation will decrease. So we go for vasodilators, diuretics, infective endocarditis prophylaxis of the underlying treatment of any underlying cause if possible. Surgical treatment is, ladies, I know the time is over. Be patient. I also know that. I already pointed out you two twin yellows. Again speaking, huh? The replacement by mechanical bioprosthetic valve, it can be open and it can be transcatheter. The transcatheter replacement is being done in our country, in Karachi, and I think they have started at the PAC as well. Aortic root replacement in case if the aortic root is dilated, for example, in syphilis, Marfan syndromes, or dissecting aortic aneurysm. Inotropic support, vasodilators, glycosides for rate control. Now, AV replacement criteria. If the patient is symptomatic, congestive cardiac failure, decreased exercise tolerance, on ETD of the patient has angina, this patient requires valve replacement. On echo, if the EF, the ejection fraction, is less than 50%, progressive LV dilatation on or decline in EF on serial studies. If you do serial studies that every 6 months you do an echo, you find out the LV size is increasing, the ejection fraction is decreasing, you decide about surgery. If the LV diastolic dimensions are more than 65 millimeters or systolic dimensions are more than 50 millimeters, that is during diastole, if it is more than 65 millimeters, or if it systole it's more than 50 millimeters, you go for a replacement of the aortic valve. Or if the aortic ring has dilated more than 50 millimeters, that is more than 5 centimeters in diameter, go for replacement. Sphere AR when undergoing cardiac surgery, for example, cardiac surgery for cabbage. So at the same time, you can also offer the patient the replacement of the valve. Now, vasodilator, as I mentioned, not indicated as long-term treatment. Vasodilators are not a long-term treatment. They can be used for short-term. Valve replacement is the preferred treatment. Where we use vasodilators, severe chronic symptomatic patients who are not candidates for surgery. When we are not going for surgery, we can go for that. Asymptomatic patients with severe AR and LV dilatation, those patients we can go for drug treatment. Otherwise, we do not go for drug treatment. It's not indicated as long-term treatment for patients who got aortic regurgitation. Patients who are asymptomatic with normal cardiac size and ejection fraction, they should go for replacement. Asymptomatic or symptomatic patients who are candidates for surgery, in those it's not a choice. So if the patient is asymptomatic, has a normal ejection fraction, normal heart, aortic valve replacement is the treatment of choice. It is not the drugs. Similarly, if the patient is undergoing surgery, you should not offer long-term vasodilator treatment. Patient be symptomatic or patient is not symptomatic and patient is going for surgery. So in these patients, we are not going to use vasodilator drugs. They are only used in patients on the left side if they are severe symptomatic and they are not candidates for surgery. Asymptomatic patient with severe disease who are again not candidate for surgery, there you can choose vasodilator therapy. Otherwise, aortic valve replacement is the treatment of choice.